There are a number of inherited forms of hyperbilirubinemia. The first is Gilbert's syndrome, which has no clinical consequences. As you can see in the diagram of a hepatocyte, Gilbert's syndrome is caused by an error either in the uptake of bilirubin from the hepatic sinusoid into the hepatocyte itself, or a mildly decreased function of the UDP glucuronal transferase enzyme. In situations of fasting or stress, an unconjugated hyperbilirubinemia may develop, with or without overt hemolysis. Crigler-Najjar type 1, like Gilbert's, involves the same UDP glucuronal transferase enzyme, except in type 1 Crigler-Najjar, the enzyme is completely absent. In this situation, bili can't be conjugated at all, and this is completely fatal. The disease presents early in life, and jaundice and kernicterus develop. The type 2 form of the disease is less severe and can be treated with phenobarbital, which increases liver enzyme synthesis. So we've discussed Gilbert's, which can be a problem with uptake, and Crigler-Najjar, which is an error in conjugation, and now we'll discuss Dubin-Johnson and Roeder's syndromes, which are caused by problems in bilirubin excretion. There are specific transporters that pump conjugated bilirubin from the hepatocyte into the bili canaliculi, and when these are genetically altered, a conjugated hyperbilirubinemia develops. Dubin-Johnson is relatively benign, with the interesting finding of a liver that is grossly black appearing. Roeder's syndrome is even milder, and does not have a black liver. Another important function of the liver is to excrete copper. Wilson's disease is an autosomal recessive disorder where the excretion of copper is inadequate, and the copper therefore fails to enter the circulation bound to ceruloplasmin. Copper accumulates in the liver, brain, cornea, kidneys, and joints. There are a variety of clinical manifestations, and they're organized here by the simple mnemonic, copper is hella bad. C stands for ceruloplasmin being low, cirrhosis in corneal deposits, known as Kaiser-Fleischer rings, which are golden brown, as well as hepatocellular carcinoma. Here's another view of the ring. Hella bad stands for hemolytic anemia, basal ganglia degeneration, asterixis, and dementia, dyskinesia, and dysarthria. It's very important to recognize this disease early on before permanent brain damage is incurred, because it's quite treatable with penicillamine or trientine to remove the extra copper. Here's another view of the Kaiser-Fleischer rings. Another important thing to remember is that it has an autosomal recessive pattern of inheritance. We just noted the harms of high copper levels, and now we'll consider the harms of high iron levels. Hemosiderosis is the term for deposition of hemosiderin, and hemochromatosis is the disease caused by that deposition. The classic triad includes micronodular cirrhosis, diabetes mellitus, and skin pigmentation, which gives rise to the nickname bronze diabetes. The cirrhosis gives an increased risk of hepatocellular carcinoma, and congestive heart failure is also a common manifestation. A mnemonic that might help you with this is hemochromatosis can cause deposits. Hemochromatosis may be primary, which is through autosomal recessive inheritance, or it can be a consequence of chronic transfusion therapy, as in patients with beta thalassemia major. Of course, the iron level is high, and the ferritin is high as well, but the TIBC is low because the body doesn't want to encourage any more iron storage in its already overloaded state. In fact, the iron level can be so high, 50 grams, as to set off metal detectors. The treatment is removal of iron with repeated phlebotomy, although deferoxamine, an iron chelator, can be used if the patient has anemia. There's an association of this disease with the HLA-A3 antigen. Okay, now we'll talk about some diseases of the biliary tract. All of these present in the same way, with pruritus, jaundice, dark urine, light stools, and hepatosplenomegaly. The labs are also the same, since they're all obstructive, with an increase in conjugated bilirubin, high cholesterol, and high ALP. However, the causes are quite different. Secondary biliary cirrhosis is a term that encompasses a number of conditions that end up impacting the biliary system, such as gallstones, strictures, chronic pancreatitis, and pancreatic cancer. These conditions can put pressure on the intrahepatic ducts by their external compressions. This leads to injury, fibrosis, and bile stasis. These diseases can also be complicated by ascending cholangitis, where organisms from the gut travel in a retrograde manner up the bile duct to cause a life-threatening infection. Primary biliary cirrhosis is an autoimmune disease. There's no preceding trigger that launches the disease. Histologically, you can see lymphocytic infiltration, which is a common finding you'll find in a lot of autoimmune disorders, as well as formation of granulomas. The test of choice for PBC is the anti-mitochondrial antibody test. Because there is an autoimmune etiology, the disease can occur with other autoimmune conditions such as CREST, rheumatoid arthritis, or celiac disease. Lastly is primary sclerosing cholangitis, the etiology of which is unknown. Histology shows an onion skin type of fibrosis in the bile duct, and ERCP demonstrates alternating strictures and dilation, which causes a beading pattern along the bile ducts. Hypergammaglobulinemia is present, and there is an association with ulcerative colitis. In fact, it's fairly unlikely you'd see a question about this disease outside the context of ulcerative colitis. Even though most people with UC are female, those that are the most prone to primary sclerosing cholangitis are males. Primary sclerosing cholangitis can lead to secondary biliary cirrhosis as well. On to gallstones. There are different causes and different types of stones. Increased cholesterol, increased bilirubin, decreased bile salts, and simply gallbladder stasis can all cause stones. The two types are cholesterol and pigment. Cholesterol stones are much more common, about 80% of all stones. They're generally radiolucent, though 10 to 20% are opaque due to calcifications. Risk factors for developing cholesterol gallstones include obesity, Crohn's disease, cystic fibrosis, use of clofibrate or estrogens, multiparity, rapid weight loss, and also Native American heritage. These are summarized by the mnemonic the 4 F's: female, fat, fertile, and 40. Pigment stones are less common, are radio-opaque, and are found in patients with chronic hemolysis, alcoholic cirrhosis, advanced age, and biliary infection, though advanced age is a risk factor for both types of stones. The diagnosis of each is generally by ultrasound now, but you can also use radionucleotide scans, and treatment is with cholecystectomy. Gallstones most often cause cholecystitis, but they can also cause ascending cholangitis, acute pancreatitis, and simply bile stasis. Ascending cholangitis can be life-threatening and is marked by Charcot's triad: jaundice, fever, and right upper quadrant pain. Additionally, many patients experience the pain of biliary colic, though some diabetics may not feel the sensation. One relevant physical exam finding is the Murphy's sign, which is considered positive if there is cessation of inspiration when you deeply palpate the right upper quadrant due to intense pain. You'll sometimes hear reference to something called a radiographic Murphy's sign, which is basically the exact same thing, except it's done with the ultrasound probe as opposed to your hand. Rarely gallstones can cause a fistula between the gallbladder and small intestine, which allows air to enter the biliary tree. In the event of a fistula, a gallstone could go directly into the small intestine without passing through the bile duct system and obstruct the ileocecal valve, causing ileus. This is referred to as a gallstone ileus. Just in case you didn't get everything about cholecystitis you needed, here's another brief view. The definition is simply inflammation of the gallbladder. Most commonly, it's from gallstones, but rarely it's also due to ischemia or infections such as cytomegalovirus. If the bile duct becomes elevated, lab tests may show elevated alkaline phosphatase. On to pancreatitis, which I'm sure you've all been waiting for. Pancreatitis is characterized by the autodigestion of pancreatic tissue by pancreatic enzymes. There are many causes, which are summarized by the mnemonic get smashed. However, the most common causes are the first two: gallstones and alcohol. The other causes do occur, but rarely, so make sure you know about gallstones and alcohol, and then study the rest. The less common causes listed here are trauma, steroids, mumps, autoimmune disease, scorpion sting, hypercalcemia, hyperlipidemia, ERCP, that would be an iatrogenic cause, and as a side effect of various drugs, another iatrogenic cause. As a fun side note, the scorpion sting is from a species that lives in the Caribbean, so if your patient hasn't been to the Caribbean recently, that's probably not a big issue. The clinical presentation is usually a very powerful epigastric abdominal pain that radiates to the back. This is a very, very, very classic physical exam finding, so make sure you know it, and make sure you know it's connected to pancreatitis. You'll also see anorexia and nausea. Labs should show an elevated amylase and lipase, with lipase being more specific. Effects of pancreatitis on the body include DIC, ARDS, diffuse fat necrosis, hypocalcemia, pseudocyst formation, hemorrhage, infection, and multi-organ failure. It can be quite life-threatening. Chronic pancreatitis refers to a condition patients develop where they keep getting episodes of abdominal pain that can progress to constant pain. Additionally, because the pancreatic tissue is progressively harmed, patients develop pancreatic insufficiency with steatorrhea, fat-soluble vitamin deficiency, and diabetes mellitus. The reasons for transition from acute to chronic pancreatitis are not entirely clear, but it's known that about 80% of patients with chronic pancreatitis have a history of alcohol abuse. Chronic calcifying pancreatitis does have an association with both alcoholism and smoking, and also signifies an increased risk of pancreatic cancer. Our last topic for the pathology section is pancreatic cancer. Pancreatic cancer generally refers to adenocarcinoma, which is the tumor histology in about 85% of cases. The prognosis is quite poor for these patients, averaging 6 months or less. The tumor is quite aggressive and generally is metastasized by the time of presentation. Cancer of the pancreatic head gives the classic presentation of obstructive jaundice. There's an increased risk among Jewish and African American males, and the main risk factors are cigarettes and chronic pancreatitis. The tumor markers tracked for this disease are CA19-9 and also CEA. There's a typical clinical presentation with abdominal pain radiating to the back and weight loss. Migratory thrombophlebitis, known as Trousseau syndrome, can be seen, and this refers to redness and tenderness on palpation of the extremities. As we mentioned, obstructive jaundice occurs particularly when the tumor is in the head of the pancreas and when the gallbladder is palpable. This is called Courvoisier's sign. As a side note, pancreatic cancer is what killed Steve Jobs, although he had a neuroendocrine tumor.